So if you can see my screen, we'll get started. So thank you guys, fourth years, for coming. This is just our sort of MedSoc's SBA series, and me and Umar will be going through some haematology SBAs today. So just sort of an overview, I guess. There's like some warm-up slides and then 11 SBAs. So we'll go through that. And then we'll have a QR code for some feedback, and there'll be two like more prolonged like case studies that we can go through. So I think there's only 3 of you, so yeah, don't be shy. Try and put things in the chat or unmute, because yeah, there's no problems getting things wrong. We're very far away from exams. Okay. Umar, can you see the chat? Okay, no. Fine. I'm just going to carry on. So I'm just going to warm up. We're going to warm up with some blood films. Can somebody just confirm they can hear me? Just because I need to know.
Yeah, we can.
Awesome. Great. Thank you very much. So does anyone know what these are? Just unmute.
Are they just
Awesome. That's right. Is it Lisa? Is it?
No, I said that.
Okay. So do you know like what might cause these?
Like TTP, HUS, DIC.
Yeah, that's great. So basically, any sort of hemolysis intravascularly. So this, I guess, this is as opposed to something happening in the spleen. Great. So what do you see here? Well, what 2 things really?
Are they spherocytes?
So kind of. Well, not quite.
Target cells?
They do look a bit like target cells, to be fair, but just generally, like as a more like general description of like how much pigment. That's kind of what we're going for here.
Hypochromic?
Yeah, perfect. Yeah, and then there's also these. Can you see my mouse? If you can, what about this sort of odd-looking shape here?
Pencil shaped?
Yes, exactly. So this is iron deficiency anemia. So you get these hyperchromasia, which is basically just the cells don't have as much hemoglobin, so they don't pick up as much as the stain. So you get this kind of really pale looking appearance. And equally, as you rightly said, we got these pencil cells, which are very narrow looking. Okay, and what about this?
It kind of looks like the Rolo appearance in multiple myeloma.
Yeah, exactly. So that's what it is. So yeah, as you said, rightly said, it's common in myeloma. Do you know sort of why they kind of do this? Why the red cells look like this?
No, I'm not sure why.
That's all right. So I guess like in multiple myeloma, there's quite a lot of proteins in the blood just because of the condition, producing a lot more of these antibodies, and that can basically just make these red blood cells a bit more sticky, and these and that means that they can basically adhere together and end up looking like this. So there you go, the increased serum protein does that. And what about this?
Are some of the cells too big?
Yeah, that's exactly. This is anisocytosis, which is a really fancy way of saying there's just variation in the size of red blood cells. So as you said, some of them are too big. and that means, so if they're too big, that falls in line with something like a B12 sort of deficiency or folate deficiency. And also, I guess some of them will be too small, so more microcytic like. So it could be that this variation maybe it's like sort of a mixed anemia where they're just deficient in both those vitamins, but anisocytosis just means variation in the size of red blood cells. Okay, so there. Okay, well, I just just flashed the answer, but does anyone want to just tell me what these are?
The target cells.
Exactly. And what might you see these in?
Hypersplenism, iron deficiency, anemia, I think lead poisoning, thalassemia,
Mhm.
sickle
Yeah,
cell. I think.
I think I'd agree with you. Yeah, so a thalassemia post-splenectomy. So my sort of like the reason, like I remember that these basically turn up after a splenectomy or like any disorder of the spleen is that the spleen is often the organ that like filters out defective red blood cells. So target cells are one of those that don't get filtered out properly. So now we're on to our first SBA. So we've got a 72-year-old female who comes in with lethargy for the first few months and some night sweats. The night sweats have been getting worse, and she's lost 5 kilos over 3 months. She hasn't gone anywhere, no travel history, but examination also reveals bruising on the limbs and slight splenomegaly. So does anyone know what the most likely diagnosis will be here?
Is it A because there's tear cell polyleukocytes?
Yeah. So myelofibrosis, yes. That is indeed the right answer. So apparently they're called dacryocytes as well, but there's all these sort of weird names, poikilocytes or kilocytes. I'm not quite sure how you pronounce it, to be honest. But yeah, um so basically if we sort of run through the other answers, in terms of malaria, she hasn't gone anywhere. So that kind of rules that out. The C and D are disorders of white blood cells, and on this blood film, there's not really many that you'd expect loads and loads of blood cells in those conditions of white blood cells. So this is clearly a disorder of red cells. In terms of anemia of chronic disease, there's not really enough else to suggest it's this specifically. There's no like kind of other chronic conditions. So myelofibrosis is a good answer. So I did a bit of reading on this, and myelofibrosis, it's scarring of the bone marrow, right? And because the bone marrow becomes kind of much more rigid, you get this kind of mechanical deformities in red blood cells as they kind of try and exit the bone marrow. So they form this teardrop shape, as you rightly said. So yeah, it's a myeloproliferative disorder, and it causes scarring of the bone marrow. So what else have we got here? So yeah, you can get hepatosplenomegaly, as you because you need to produce red blood cells elsewhere, and the spleen and the liver can therefore grow in size in order to compensate. You'll get some high uric acid levels, which will cause itching, and that's because there's basically more there's less maturing of all of these blood cell types in the myeloid line, which means you get loads of these progenitors, which means that there's a lot of these progenitors breaking down. So this like higher turnover means you get higher uric acid levels. And the easy bleeding and bruising can come from just basically not having enough platelets. Right. And yeah, in terms of treatment, transfusions, EPO for the anemia, and you can get some more specific sort of biologics targeting the JAK-STAT pathway. Okay, so let's go to number 2. 24-year-old male referred to haematology from ED. His main complaint is abdominal pain, which started a few hours ago, and he's getting progressively worse. So what's the most likely cause of his abdominal pain? Sorry about that, guys. So if we sort of start to break it down, going through the blood tests results, so his hemoglobin's low, so he has an anemia. His hematocrit, which is basically the amount of red cells in his plasma, is also low, but his reticulocytes are high. So if his reticulocytes are high, that normally means that his red cells are basically, they're trying to replace his red cells, because reticulocytes are like the progenitors that occur right before red blood cells. So something's destroying the red blood cells.
Has he got sickle cell crisis?
Yeah, exactly. And that's also probably why he's got the abdominal pain, right? Yeah, so one of the complications with a crisis, which is where the cells, like in sickle cell, basically the main problem with the disorder is that like the cells take up the sickling shape, and that can basically stop the blood flow to certain areas and also cause a lot of pain as these cells like basically drag alongside tight blood vessels and tight capillaries. And yeah, you can get abdominal pain because of these crises happening. So in terms of going through the other answers, so polycythemia, you'd basically expect a lot more red blood cells. So you'd expect this hematocrit to be higher. In terms of myelofibrosis, well, if you look at the bottom two, his bilirubin's a bit high, which happens. One of the reasons bilirubin can go up is because red blood cells are basically being broken down, and his reticulocytes are also high. So it's suggesting some kind of hemolysis, and that doesn't really happen in myelofibrosis.
I'll play that. No, that's fine.
Cool. Terms of hello. Cool. Okay. In terms of hematochromatosis, yeah, so I'm not sure, to be honest. I think it says here high red blood cell production. I'm not sure what that means, to be honest. And yeah, so the last one, microcytic anemia. Basically, reticulocytes are really big, and they drive the mean corpuscular volume up. So if you have a microcytic anemia, it doesn't really fall in line with having more reticulocytes because these cells are bigger than the more mature red blood cells. Okay, is there any questions about that or anything so far? Okay, I'm going to move on. So SBA 3. I'm going to let you guys read this, and if someone knows the answer, just tell me what the most likely organism to cause this presentation will be. Give you a couple minutes to read it. Okay, so from the start, this patient's Afro-Caribbean. He's had a crisis, which would hint towards sickle cell disease, and he's had a splenectomy as well, which would further put him at risk of like basically getting infections, and he's got a fever and a limp. So the fever and the limp makes you start to think about bone infections and osteomyelitis. So really from here, it's about whether you know the most common cause of osteomyelitis in sickle cell patients. So it's basically it's salmonella. So normally osteomyelitis is most commonly caused by Staphylococcus aureus, but in this specific population, most common cause. Cool. So yeah, sickle cell disease, as you might well know, is autosomal recessive disease. It's caused by basically a defective beta hemoglobin. So it can cause an anemia, and there are several complications like an acute chest syndrome or crises. In terms of investigating for this, you'd need to look at the full blood count. You want a blood film, and you also want hemoglobin electrophoresis. This is the best way to sort of definitively diagnose the genotype. So whether this is a carrier or whether this is a full-blown sickle cell disease. Management-wise, you can basically treat the patients more long-term with hydroxycarbamide. And what this does is increases fetal hemoglobin. So if there's more fetal hemoglobin, then a lot of red blood cells don't need to. There are a lot more blood cells with fetal hemoglobin and alpha hemoglobin, and less proportion of blood cells with the defective beta hemoglobin, which means that there will be less blood cells that can sickle with this basically this dodgy beta globin. And you can also vaccinate these patients against Neisseria, Hib B, and strep pneumo, basically. Okay. Any questions about that? Cool. Oh, right, yeah. So I was mentioning this before. There are basically a bunch of different crises that can happen in sickle cell. One is called aplastic crisis. So when sickle cells get this virus called parvovirus B19, which is will present with these patients getting really red and flushed cheeks, it can cause an aplastic crisis. So it will drive all of the blood types down, and this can put them at risk of infections as well. Vaso-occlusive crisis, as we've sort of talked before, and splenic sequestration, which can lead to sort of splenomegaly as well. And we've just talked about that, haven't we? Okay. I haven't really mentioned this. Acute chest syndrome is basically a type of vaso-occlusive crisis, but it specifically occurs in the lungs. So they'll get a painful feeling in their chest, and they'll get very hypoxic. So these patients are in quite a sort of critically ill state, and they often require a referral to ITU to help give them ventilation support as well. So right, so we're on SBA 4 now. So a 78-year-old female presents to the GP clinic with her carer, complaining of lethargy for the past 2 months and tingling in her fingers. So she looks quite pale. She has a past history of dementia. So looking at the options below, what's the most likely cause of her B12 deficiency?
Is it dietary, so not taking in enough B12?
Yep. Would you like to sort of try and expand on that a little bit? That's right.
I knew it was. I think I knew the most common was like either pernicious or anemia or dietary, and I just thought maybe since she's elderly, got a dementia. I just thought maybe it'd be like dietary, not taking it in enough, and then it would be an absorption and anemia kind of related.
Yeah, that's great. Yeah. So the key thing here is she's come in with her carer, and she's got dementia. So very common thing with people with dementia is they forget to eat their food, and clearly she's dependent because she has a carer. So in terms of the other options, pernicious anemia again is another very common cause. I would expect probably a slightly younger person coming in with this disease. And some in SBA land, there's always some kind of a hint towards like autoimmune or something that comes alongside pernicious anemia. So Crohn's disease is a similar thing, younger. So you'd expect a younger patient and you'd expect GI symptoms. But like they could absolutely have a B12 deficiency of Crohn's. It would be very much a similar case of flushing out a lot of the vitamins taken in, but too old. Yeah. Trauma, there's like no evidence of trauma here. And again, Gaucher's disease is it's this quite rare metabolic condition, and is much more common. Like at the age of onset is normally about 20 years old, so way too young for that. So more on Gaucher's disease, it's pretty rare. We might not need to know about it, but it's a condition affecting the metabolism of certain lipids. So there's a lipid called glucocerebroside, and this can accumulate in tissues and have quite widespread effects. That's what Gaucher's disease is. Okay, SBA 5. So a 32-year-old female presents to the GP clinic with heavy periods for the last 18 months. She experiences nosebleeds twice a week for the last 4 months. And on examination, you find some purple nodules on her buttocks. So of these 5 options below, what would the most likely diagnosis be? All right, so we can try break the question down a little bit now then. So for one, obviously this person has quite an extensive bleeding history. She's female, but we can start to rule out some of those options because her symptoms are very limited to sort of clotting / coagulation related problems. So I wonder if that helps anybody. Okay. So the most likely answer is immune thrombocytopenia. So if I believe I'm correct in thinking that haemophilia B is X-linked recessive, right? So you'd actually expect to see that in a male. So that is one quick way to rule out that. The other thing with haemophilia B is that haemophilia, the way in which people bleed with haemophilia is typically bleeding into the joints, which is something called hemarthrosis. Aplastic anemia, so you could expect bleeding, but you'd probably also expect infection, and I would also probably expect infection in the white cell disorders as well. So both the leukemias. Chronic lymphocytic leukemia is commonly like slightly older population as well. And acute lymphocytic leukemia is very much on the other side. It's a pediatric condition. So normally I think it's like under 10s, to be honest. So you can rule out a lot of those conditions based on what else you'd expect to see, as well as like the demographics in those conditions. Immune thrombocytopenia is quite common. It's also autoimmune in nature, and that's typically more common in women for reasons that I don't know. But yeah, it's a very common cause of thrombocytopenia. So what happens is you get autoantibodies against platelets, and yeah, it can actually occur after an infection. So that's another key indicator. I don't know, this woman didn't have any infection, but that's another thing to look out for. It can happen after like some kind of upper respiratory tract infection, things like this. And you're looking at bleeding from the gums when they're flossing, or nosebleeds, epistaxis. In terms of investigations, with a lot of things, you always want a full blood count, really. You want to look at the blood film, and you can also just test if you suspect it, you can test the autoantibodies against the platelets. So the treatment is basically none if mild, but if you want to treat it, you can give corticosteroids, or you can give an immunoglobulin. Does anyone know why you wouldn't give them platelets?
Because the body just breaks it down after.
Exactly, yeah. You just give them platelets and the bodies will just destroy the platelets you give them. Much more further down the line, and probably much rarer, you can also you can basically just replace, you can take out their spleen, and you can give them some sort of biological therapies like rituximab to try and really dampen down the inflammation that's targeting the antibodies. Okay, I'm going to stop sharing my screen now, because this is where Umar will probably take over.
Yeah, I'm going to try and just share my slides if I can. Present. Not sure if that's worked just yet. Is that working, guys?
Yeah, I can see it.
Yeah. Let's just... Okay, can everyone see that?
Yep. Yeah, go ahead.
Okay. I'm not sure how to get the chat on the same page. So if you see anything, Josh, would you just let me know? Any questions?
Yeah, I can do that. No problems.
Yeah, thank you. Okay. And also, if anyone wants to kind of ask a question, just unmute yourself at any point. It's fine. Yeah, I'll try to answer as best as I can. But it has been a while since haematology. So, anyways, so SBA number 6. So we've got a 65-year-old male who presents with 5 kg of weight loss over the last month and night sweats. He looks pale and clammy, and he's got a large spleen and liver. His blood test shows leukocytosis. What would be the most definitive investigation to confirm his diagnosis? And just unmute yourself and put it in the chat. Let me know what you guys think. Oh. Oh, sorry, didn't mean to do that. No, did not mean to do that. Sorry. What's happening? Sorry about this, guys. Yeah. So if anyone would like to say their answer out loud, well, I'll give you guys a bit of time just to read it. Anyone got an idea? No, well, if not, let's kind of break it down a little bit. So we've got a 65-year-old male here who's presenting with kind of weight loss and night sweats. Now, if you remember from your kind of OSCE practice in terms of the things you always ask, B symptoms are very important to ask, and those include fever, night sweats, and weight loss. So whenever people are presenting with those kind of symptoms, especially 2 of them, and kind of especially weight loss, that's the most important one we always kind of think about for a red flag, it screams cancer to us already, just in terms of that first sentence. And it's a 65-year-old male, maybe increased age could be a risk factor. So we always got to think cancer. Now, he looks pale and clammy, and he's got an enlarged spleen and liver, and his blood test reveals leukocytosis. So that, again, has told us a few different things about what is going on with this patient, but it's not told us everything. Because this is the thing you guys got to remember, with heme cancers especially, it's very difficult to diagnose them purely off symptoms and kind of a blood test, because like they present very similarly, kind of all the different leukemias and stuff like that. And you got to just be careful in terms of when you think about stuff like that. And then the final thing, so what you try and do when you read these questions when it comes up in the real exam, because this is a very fair question that could come up in the exam, you break down the question into different parts, and then when it comes to the final part of the question, you've got to read the actual word, most definitive investigation. Already that should be screaming to you, okay, well, it can't be a full blood count, because that's very rarely a definitive investigation, especially for a hematological cancer. And already, if you think about it, his blood test reveals leukocytosis, which means full blood count's already been done. These are the kind of things that you should be thinking about when you're going through a question, you're going through the options. You should be thinking, is this feasible? Is this actually going to answer the question? And then we'll move on to cytogenic analysis of bone marrow. So when we're looking at that, that does seem like a definitive investigation because it's quite invasive and it could be an answer. So that's in our mind. And then we look at blood film. Again, is blood film going to be definitive? It's unlikely to be absolutely definitive because it can be quite similar on a few different conditions. Direct Coombs test, I mean, that's more for the hemolytic anemias. We're not really thinking hemolytic anemia in this particular scenario. And finally, a CT scan, I mean, it's going to show the enlarged spleen, it's going to show the enlarged liver, but that's nothing we don't already know. It's not going to tell us the source of the cancer slash kind of what is the diagnosis. So that's why for this, I think the answer is cytogenic analysis of bone marrow. And when you're thinking about stuff like this, always just bear in mind the actual wording of the question, because sometimes they're going to be saying what's the initial investigation, and that's going to be completely different to what's the most definitive slash what's the gold standard. Yep. Okay. Let's move on to question 7. So we've got a blood film here, as well as a few symptoms of fever, night sweats and weight loss, as well as gum hypertrophy. I'll give you guys a minute just to read that, think about it. If anyone's got an answer, or just even would like to talk through what they're thinking, don't have to necessarily give me the answer or give me what's in the blood film, just what's going through your mind. Because each time a question is presented to you, something should be going through your mind, a process by which you're thinking.
Yeah, I'll do it.
Oh, whoever wants to go.
I'll go. So I'm thinking A, because the blood film is showing A rods, and also gum hypertrophy. The only one where you'd find gum hypertrophy is in acute myeloid leukemia.
Yeah, that is exactly what we're looking for here. So yeah, again, we've got a fever, night sweats, weight loss. Instantly, we're thinking a cancer or something like that because there's B symptoms. And then gum hypertrophy, it is specifically linked to kind of AML or AML-like different versions of AML. And then finally, the blood film does show the following. It is our rods that we've got here. They're kind of, not sure exactly how to describe them, but you can kind of see the cytoplasm within the outer circle. And yeah, it's something that don't get too kind of fussed about, but if you see it a couple times, if it comes up in the real thing, you'll be able to spot it. And that's the case with a lot of these heme blood films. Just like, don't stress out too much about it, but just see them. Like, you'll see them in questions whenever you do questions or anything, but just get used to them a little bit without, like, you don't have to be able to draw it from your own memory, because that's never going to happen. It's always just going to be a spot diagnosis, and most of them you should be able to tell the difference, I reckon. Okay, so yeah, this one is indeed AML. If we think about some of the other options, kind of ALL is more in children, so you wouldn't really expect to see a 60-year-old presenting with ALL. And the CML and CLL would present differently on kind of blood film, and also the gum hypertrophy pushes you massively towards AML. So yeah, let's talk a little bit about the leukemias. So we've got kind of 2 different types, of myeloid and lymphoid, and then within each of those types, acute and chronic versions of them. So AML kind of is normally in the kind of people with 60s, people in the 60s, kind of gum hypertrophy, aware rods, they're the things to be looking for in your SBA about that. Find acute kind of lymphoid or acute lymphoblastic leukemia, most common in children. So kind of especially when you're seeing a child presenting with anything like different rashes or platelet disorders, things like that. ALL should be on the top of your mind, especially like kids with easy bruising. And yeah, sometimes it can have a bad prognosis, but I think overall it's not. You know, there is good treatments for it in children. In terms of CML, then it's most commonly kind of the Philadelphia chromosome. That could be kind of a random question they stuck in there with translocation 922. It's more commonly in CML. And then there's a drug you can give, imatinib, which is a tyrosine kinase inhibitor. And again, the age is kind of between 40s and 60s, you more commonly see it. And then finally, CLL, kind of a B-cell malignancy, and normally found incidentally on blood count or something, doesn't present that often with symptoms, and more commonly in older people for sure. Okay, let's go on to the next one. Okay, so you're an FY1 on the haematology ward. A nurse calls you to examine a patient who's been feeling progressively weak. On examination, you find absent knee and ankle jerks and reduced sensation below the knee. Which of the following medications has caused his presentation? And yeah, just I'll give you guys a minute just to kind of think through this, and then if someone wants to unmute there and just again talk through their thinking behind what's going on.
Is it maybe C?
C, so folate supplements. Is that what you're thinking? Why do you think that?
Because if they're having absent knee and reduced sensation, I thought that like if you have pernicious anemia or B12 anemia and then you gave them folate, that can make it worse because of subacute degeneration or something.
Yeah, that's kind of exactly the thought process we're going through here. So we've got someone who's been feeling progressively weak, and then they've got absent knee and ankle jerks and reduced sensation below the knee. Those are kind of in our mind that should be pointing towards something called subacute degeneration of the spinal cord, which basically, if you correct the folate deficiency, or if you give them folate before you've corrected the B12 deficiency, that can precipitate a subacute degeneration of the spinal cord. So initially they'll have a B12 deficiency, which maybe isn't causing symptoms, and then you give them a folate supplement, and then probably due to some complicated pathway that we really don't need to know, that causes subacute degeneration of the spinal cord, which can happen in kind of severe forms of B12 deficiency. So yeah, that's what we're looking for here. But also, like, if you kind of have no idea about this kind of question, just go through the different options and try and think, does that make sense? Can I imagine that being the answer? And then more often than not, it'll end up coming to the right answer because you've ruled the other ones out. And it's a good way to get kind of those marks where you think I have no idea. You can get more than you think from just ruling things out by thinking, does this actually make sense? Could I imagine this being the right answer? But yeah, so always prescribe B12 with folate supplements to avoid that kind of subacute combined degeneration of the spinal cord, which would present incidentally like obviously this, the reflexes being reduced or absent, and the sensation as well. Okay, next, SBA 9. A 5-year-old boy presents with a weak history of abdominal pain and bloody diarrhea. Examination reveals pallor and petechiae. 3 days prior, they had a family camping trip where they ate burgers for lunch. Now, this is a kind of two-step question, which UCL love to kind of put in there. Given the most likely diagnosis, what is the most appropriate management? So first, you've got to think what the most likely diagnosis is, and then following on from that, what is the most appropriate management? I'll give you guys a minute just to think through your different options, your differentials, and then we'll talk through it, or someone can unmute and talk me through the answer. Okay, if no one's too sure, let's talk through it then. Okay, so a 5-year-old boy is presented with kind of abdominal pain and bloody diarrhea. So instantly when we read that sentence, there's loads of differentials that can go through in our head. I guess we should always think common first. So common things we can think when a kid presents with abdominal pain and diarrhea of any kind, but especially bloody diarrhea, we can think of gastroenteritis, we can think of infections, we can think of things like that as kind of the top of our list. And then we've got examination reveals pallor and petechiae. So that's kind of already pointing us towards, okay, something's going wrong here. This is not a normal gastroenteritis. This is something different or a more severe form. And then they've got the big clue of the family camping trip where they ate burgers for lunch. Now, this is kind of a condition that I wouldn't say it's a niche condition. I'd say it's an important condition, but it's maybe one that not everyone always thinks about. And it's to do with a specific kind of toxin and bacteria. Does anyone know what condition we might be talking about?
Is this Campylobacter jejuni?
So I can see why you're saying that, because it does also present with bloody diarrhea and abdominal pain, but it's less likely to present with the pallor and the petechiae. And in terms of when it's talking about a family camping trip where they ate burgers, there's a specific other thing they're looking for that is more likely to cause this specific condition.
Is it hemolytic uremic syndrome?
Yes, hemolytic uremic syndrome. That's exactly what we're looking for. And that's kind of, do you know what the cause of it is, or most commonly?
Isn't it like E. coli 0157? The name.
Yeah, exactly. E. coli 0157H7, something like that. I don't think you need to know the exact, just be able to recognize that maybe the 0157 bit, that's leading towards hemolytic uremic syndrome. What this is basically a condition where it's a triad. So there's 3 different parts to it that you kind of need to know. So there's AKI. Now, obviously, you can't tell an AKI from this question, but that's just generally what they might be having. An AKI, microangiopathic hemolytic anemia, so a form of kind of anemia where there's hemolysis, and finally thrombocytopenia as well, which kind of makes you, that's why the pallor and the petechiae, that's all happening because of those different symptoms. Okay, and the other clue is kind of family camping trip where they ate burgers. That's normally the thing they kind of say, which then causes this in kind of SBA land. That's what we're looking for. Okay, so what it is, it's the E. coli producing a toxin, which is then causing the symptoms. Following on from hemolytic uremic syndrome, that's the diagnosis. That's part 1 of the question. With these 2-step questions, you kind of have to break it down into that form. You have to think, okay, what is the diagnosis? And then following on that, what is the management? Does anyone know what the management of hemolytic uremic syndrome is? And or give the answer to the question.
Would it be C, supportive?
Yeah, exactly. Supportive treatment only. Does anyone know kind of what would you say about answer A? Because you might think it's a bacteria, E. coli. Let's give some IV antibiotics, that might help. Why do we think that's not the case? Try and think about what's going on with the patient, what's going on inside the patient, and then what antibiotics do. Okay, well, if we think about it, antibiotics will destroy bacteria. So in our case of hemolytic uremic syndrome, what's happening is the E. coli 0157 is producing a toxin. The toxin's called the Shiga toxin, something like that. And that's then what's called. If you go on to give them antibiotics, that will destroy the bacteria, yes, but that will cause a massive efflux of the toxins, which will significantly worsen the condition of the child. So it's just something to remember. Don't give antibiotics in hemolytic uremic syndrome. And then when you kind of have these facts like that, I think it's a lot easier to remember if you understand why, rather than just remembering a fact like don't give antibiotics in hemolytic uremic syndrome. Understand why that's the case, and then it's like it stays in your memory a lot longer. Steroids is not kind of the option. Transfusing packed red cells and whole blood isn't really going to help in this situation. Fluids, kind of, unless it gets really severe, then maybe you could do dialysis or something like that to kind of get it out. Plasma exchange is also seen as an option, as well as some kind of monoclonal antibodies that we don't really need to know about. Okay.
Can you just quickly explain the why you don't give antibiotics again? Because your thing went mute just as you.
Oh, sorry about that. The reason you don't give antibiotics is because in this case, so in hemolytic uremic syndrome, the thing that's causing the symptoms is it's not necessarily the bacteria, it's the bacteria is producing toxins, and those toxins are being released into the blood. It's not the actual bacteria that's causing the issue, if you kind of understand what I'm saying. So what happens if you give antibiotics, I think it would, what happens is it destroys the bacteria, which causes a massive release of those toxins into the bloodstream, which is then what's going to cause further worsening of the symptoms, especially in the short term. That's why giving antibiotics is not kind of recommended for HUS.
Got it. Thank you.
Okay. Okay. So yeah, secondary is kind of E. coli or Shigella as well, and it's that endotoxin initiating the inflammatory response. The triad is AKI, hemolytic anemia, and thrombocytopenia. There's a kind of investigation set you could do. You could look at complement pathway because this E. coli causing HUS, that's a secondary cause, and it is the most common, but primary cause of hemolytic uremic syndrome is actually due to kind of complement dysfunction, so problems with the levels of C3, C4. So that could be part of your investigations list. And then treatment supportive, and yes, so do not administer antibiotics. It could cause an efflux of the toxins, which worsens the condition. Okay, fine. SBA number 10 now. 78-year-old female has been admitted for pneumonia. She has COPD and takes warfarin for AF. Her target INR is 2 to 3, but it's rose to 5.6 now on the third day of admission. Which drug is most likely to have caused her increased INR? I'll give you guys a minute or two for this just to work it through. Okay, fine. Let's break it down then. First question then that I want someone to answer is, what is INR? What does it mean? What does it measure? What does it stand for? Anyone know what INR stands for and what it means? You can put it in the chat as well if you're not.
Isn't it just like the prothrombin time compared to like a normal international score?
Exactly. The international normalized ratio, INR. And what does an INR basically mean in terms of bleeding?
Yeah, so I think it reflects the prothrombin time.
Yeah, exactly. But in kind of simple terms, in terms of the bleeding, if you've got
Oh, right.
high INR, what does that mean?
You bleed more, or yeah.
So if you've got a high INR, it will take longer to clot, which means, yeah, you will bleed faster. Okay. And then what is warfarin? What does warfarin do? Anyone can respond. What is warfarin? as a class of the drug?
Vitamin K antagonist.
Vitamin K
Anticoagulation.
antagonist. Anticoagulation, yeah. Always kind of simplest answer is the best answer. It's an anticoagulant. So that means that warfarin is looking to stop the coagulation of blood, which is obviously why you worry about bleeding on people in warfarin. So warfarin will naturally increase your INR because it will make your blood take longer to clot. Okay, so in this case then, our INR has risen from 2 to 3 to 5.6. What does that mean for the levels of warfarin in the blood? Has it gone up or down?
It's gone up.
It's gone up, exactly, because our INR has gone up and our warfarin is basically acting to increase our INR, but we want to be careful about increasing our INR too much because that means we're going to bleed quicker and it's more likely to cause kind of death by just bleeding out. Okay, so we've got an increased amount of warfarin in the blood. What does that mean is not happening to the warfarin now as much as it was before?
It's not being metabolized.
It's not being metabolized. It's not being broken down. And if something's not being broken down, obviously it's going to increase its concentration and how much of it is in the blood. So what metabolizes warfarin?
Like P450 inhibitors.
So in terms of the question asked what metabolized warfarin, so what's metabolizing it is that kind of P450 enzyme. And then so there's these things that kind of can stop or inhibit the P450 enzyme and things that can induce it. So in this case, obviously our P450 enzyme is not working as good as it could anymore, which is why our warfarin's going up. Therefore, we're looking for a P450 inhibitor. Does that kind of make sense to you guys in terms of the way we're thinking about that question, the process we're going through? Okay, fine. That's good then. So then from there, once you've done all that, thinking about is it going to be an inhibitor or an inducer of P450, from there it's a kind of memorization game. There's different acronyms people use for inhibitors and inducers. I'll go through them on the next page, but does anyone know what the answer to this question might be?
Is
We're
it
looking for
clarithromycin?
clarithromycin, exactly. So we're looking for a P450 inhibitor, and in this case, that is clarithromycin. So the two acronyms that I used to use in fourth year were sickfaces.com for the inhibitors. I'm not going to read out the whole list, but there's a lot of them there, and crap GPS for the inducers. And it comes up a little bit. I mean, it's not obviously the most important thing to learn all of these different drugs, but I'd say some of the more important ones could include kind of clarithromycin, maybe omeprazole, things like that might be more important, sodium valproate as well. And then for the inducers, I'd say the carbamazepines, sulfonylureas as well, probably the more important ones to think about. Okay, I think that's my, one more. A 23-year-old then, female patient presents with pallor, fatigue, mild jaundice, which worsens in the summer and gets better in the winter. Her blood test results are as follows. You can see her different blood test results there. What's the most definitive investigation to diagnose her condition? And again, I'll just give you guys a minute or two just to think about this. Okay, so you want to be thinking about things here that can. Oh, yeah, go on. Sorry.
Maybe A.
Okay, why are you thinking A? What are you thinking it might be?
So there's loads of reticulocytes, which means that they will have a bigger cell size. So even though the MCV looks normal, we're probably seeing a microcytic anemia.
Okay, I see what you're saying. But in this case, you're trying to think, would that cause something to be worse in the summer and get better in the winter? Or is there another condition that we can think that might be like that?
Sickle cell.
Sickle cell can be kind of triggered. You can get like crises based off exposure to cold and things like that. But I wouldn't necessarily class it as the main condition we're thinking about, which worsens in the summer and gets better in the winter, and would cause these kind of findings on blood tests. It's a difficult question, don't get me wrong. But there are two types of this specific condition, and they differ.
Is this the cold and warm AIHA?
Yeah, exactly. So autoimmune hemolytic anemia, and there's a kind of cold one, which is kind of lower temperature, like 3 or 4 degrees, and there's a warm one as well. And for that then, for autoimmune hemolytic anemia, what kind of diagnosis do we think?
D.
Yeah, the direct Coombs test, which was kind of specific to autoimmune hemolytic anemia, and yeah. Okay. So yeah, here's the two differences between them. So kind of 37 degrees for warm, 4 degrees for cold. IgG for warm, great weather, if you want to remember it like that. I'm not exactly sure. IgM, I guess, maybe miserable weather, you can think. And different kind of causes of each of them, and the different kind of treatments you can do. So steroids, splenectomy, avoiding cold, and rituximab, maybe a monoclonal antibody for that. Okay, I think we've got a feedback form, and then Josh is going to do the case. So if everyone could just do this feedback form. I think it works. I hope it's not from previous year. Josh, do we know if we uploaded the new?
Yeah, I'm pretty sure this is the new one.
Okay, fine. That's good. Yeah, so if everyone could just do that, and then Josh, just let me know when you're ready to switch over for kind of sharing.
Yeah, we'll do. I guess there's also an opportunity for you guys to have like 2 minutes or whatever for break, have a drink.
Yeah.
Okay, guys. So yeah, we'll put the form back up at the end of the tutorial as well. So I'm probably just going to start sharing my screen, and then we can get going again if that's all right. So, okay. Can you guys see my screen?
Yep.
Awesome. Okay, so what we've got now is just two like long cases, and then that's basically it. So you guys sort of just get yourselves ready. Now this is case one. So we have a 42-year-old previously healthy male, and he comes in with increased fatigue and exertional shortness of breath, basically dyspnea. Okay, here we go. And so you examine him and you see pallor, but you don't see any lymphadenopathy or splenomegaly. Okay. So you do a full blood count. Should come up in a second. Okay. And all right. So this guy has low hemoglobin, so he's anemic. His white cell count is actually within the normal range. And his platelets are quite low indeed. So based on what we've seen so far, does anyone sort of want to tell me where their mind might be tending to in terms of differentials? No like specific answer, but based on what we've seen so far.
I'm thinking some kind of microcytic anemia because of the low hemoglobin, the pallor, increasing fatigue, exertional dyspnea.
Yeah, that's a very good that's a good shout. Definitely. Anything else? We've got low platelets, a couple of other sort of systemic signs as well. Okay, cool. So yeah, I guess low platelets and low hemoglobin means okay, there's multiple cell groups affected. We've got red blood cells are down, and so are our platelets. So maybe something with the bone marrow is going down. And I suppose there are a lot of things that can actually impact that, which we'll go into. I've got to see what happens now if I press this. Right. So yeah, we've got some differentials already. As I said, microcytic anemia. This guy's tired and pale. But is there any other things that might include also thrombocytopenia as well?
Sepsis.
Good shout. So is there anything you're specifically thinking of sort of down the line there?
Nope.
Yeah, so like a common thing in sepsis is DIC, like they kind of go often hand in hand. So that's a very good differential. Yeah. So we got sepsis. This could still be some kind of a cancer as well. No, there's no like obvious weight loss, but it's there. and we've talked about sepsis. Some viruses can also cause like aplastic anemias or like bone marrow suppression. So thinking along the lines, we just want like a broad scope of what could be happening here. Yeah, so immune thrombocytopenia, but yeah, I mean, you wouldn't really expect an anemia to here. So leukemia. Now, it's interesting, it's leukemia, but probably not lymphoma, because we don't have any lymphadenopathy and we don't have any splenomegaly. So that like lymphoid system and all of that sort of lymph tissue isn't affected. Oh God, okay. So I kind of briefly flashed it there, but you see this man, he's come in with these sort of vague things. You've got a full blood count. What other sort of investigations might you want to do to sort of gradually rule things out? Any ideas?
Would you do a blood film to help you
Yep.
identify the different types of leukemia?
That's a very good.
Maybe
That's a very good
iron-
shout.
Iron studies.
Yep. Yeah. So you've got sort of thrombocytopenia. So on similar lines, is there anything else you might want to test out? Yeah, so okay, well let's go through it. Let's go through it. So he's already done a full blood count. Someone said blood film, very good. You could do sort of coagulation screen. So that's sort of going to thinking about prothrombin time and APTT or fibrinogen. That's probably because of DIC that kind of affects loads of different clotting factors in that system. So Usenease is an interesting one. It's kind of, it always rolls off the tongue, SBCs, Usenease, LFTs, but Usenease here, it gives you a baseline, like how good are their kidneys doing? And sort of more thinking about the anemia here, kidney failure, especially like chronic kidney disease, can be a cause of anemia. The tumor lysis screen is an interesting one. So yeah, we've got calcium and potassium, all of these sort of like intracellular ions and LDH. Can anyone think why we might do a tumor that be testing LDH specifically? So LDH, it's basically a good marker of how quickly cells are like dying and sort of dividing as well. So it's typically higher in a lot of cancers, but as someone mentioned earlier, it might also be heightened in things like sepsis. So a good thing to do. LFTs, so a lot of coagulation, sort of not quite, well, yeah, a lot of the clotting factors and stuff made in the liver, and it also some kinds of viruses can inhabit the liver. So that's also why we're thinking hepatitis and HIV, because both of these viruses might cause some kind of bone marrow suppression. And flow cytometry. So Umar was saying earlier, like a lot of sort of leukemias and lymphomas can present very similarly. So this is it's a lab technique to basically isolate different types of like blood cells or like blood cell progenitors. So you can see like how much of each one there is and which one's basically proliferating hugely. And if you can isolate that type, you can sort of figure out where in which side of the lineage are, because you have myeloid types and you have leukemias or lymphoid types. So that lab technique can help you there. A bone marrow aspirate, so just taking a look at the bone marrow and what the cells are looking like in there. And yeah, if you're thinking along the lines of lymphomas, or is this sepsis, you can also do septic screen and chest x-ray. So yeah, I mean, this is quite a long list of further investigations. I think in real life, you would probably take quite a long history and rule out a lot of this stuff beforehand. So I don't know if you'd need to remember all of these, but certainly some of the thoughts that you guys expressed with regards to full blood counts, blood films, is this sepsis, you know, so septic screen, just sort of working through that sort of surgical sieve you have and ruling out different causes of thrombocytopenia/anemia, always good. If I were to push, just choose like the most important ones: full blood count, blood film, coagulation. Using these LFTs, you always throw in there, and then you could possibly look at flow cytometry as well, maybe further down the line. But okay, so that's the sort of further investigations we have. So on the blood film, this is what you see. Does anyone know what this is?
Is it an IO rod?
Yes. So what does that sort of make you start to think of?
Acute myeloid leukemia.
Great. Yeah, exactly. So our rods are basically these like these odd sort of structures found within the cytoplasm, and it's typically a cause of acute myeloid leukemia, or not a cause, is associated with it. So the myeloid like lineage, or like the myeloid side of the, if you know the stem cell tree and how things sort of differentiate, the myeloid side give rise to like granulocytes, so like your eosinophils and like your macrophages, and all of these cells have loads and loads of granules in them. So what happens is, as these myeloid cells, they don't mature, these little like lysosome granules. So if you remember from preclin, the lysosome granules are like, they have like sort of enzymes, they clear up cellular debris. So these lysosome granules, they basically fuse together and form this rod shape. So that's why it's more of basically a sign of something going wrong with the myeloid side of the tree. So yes, acute myeloid leukemia, that's what we're starting to worry about here. You can see that the myeloblasts, they're much higher than you'd expect them to be, and they contain these Auer rods. So you can, once you have sort of a bone marrow aspirate, you can do some further tests. You can stain them, obviously, and you can look at cytogenetics. So I believe cytogenetics is basically where you are looking at chromosome changes, because Umar mentioned before earlier as well, like there are certain like translocations, so like the Philadelphia chromosome and several others that are associated with certain types of leukemias. So that's one thing that can help you isolate what cell type is kind of going rabid at the moment. And yeah, so in acute myeloid, there's the myeloid leukemias is acute and chronic, right? And in acute, this onset, as the name suggests, is very quick. You get these massive explosion of these immature blast cells, and as a result, this almost, what happens is they don't mature. You have a really low white cell count. In the chronic myeloid leukemia, not really 100% sure exactly why, but I guess the transformation is a lot slower, and you get much more of these much more of these progenitors maturing fully into white cells. So if you have like a full breakdown of the white cell types, if you see more blasts, you start thinking this is more acute. And if you see you see like more approaching more normal white cell count, this might be more chronic in nature. Obviously, the history will also be a lot different if it's acute. Okay, I'm going to go back there. So that next slide was basically on the presentation of leukemias. If you guys start thinking of going like head to toe in the body, what kind of symptoms might present with a leukemia?
Would you have like the B symptoms? So fever, night sweat, weight loss.
Yeah, certainly. So you can also think about, yeah, go for it.
Splenomegaly.
Yeah. Yeah, I guess, yeah, some leukemia as well. And if you're thinking about like what's getting knocked out, you don't have any, what kind of lineages are getting knocked out, and therefore like what symptoms will those deficiencies cause, you can start to think of more symptoms. Yeah, so what I was sort of thinking of is like with leukemias, you're going to get low blood cells, so you might get start to get short of breath. B cell symptoms is great, but you might also get yes, you'll get some tiredness. If you don't have as much platelets, you might start bruising. If your white cells are low or affected, you might start getting loads of really severe infections, which kind of links to the B cell symptoms, I suppose. So that's great. What else have we got? So frequent infections, here we go. Weight loss. So like every cancer, that's going to be the case. We've got shortness of breath. If these are lymphomas, you might start getting lymph nodes. And sometimes in lymphomas, the lymph nodes can sort of compress on, they can compress or push the sort of trachea to one side. So you might get some weird breathing kind of symptoms. As you said, hepatosplenomegaly, so that's great. Night sweats, easy bruising, and you might get bone tenderness as well. Great. So we were sort of speaking earlier about, yeah, how specific these blood cancers can be. If you're trying to differentiate between myeloid and sort of like lymphoblastic leukemias, you basically just want to find out like the cell type, the very specific cell type. And you can do this with cytochemistry. So the chemistry bits, it suggests, certain stains, immunophenotyping. So you can take advantage of the like molecular markers on the surface and try and isolate cell types by that. That's what these CD markers are here. So there'll be a lot of cell types have a very specific, it'll be CD and then some kind of number here, and they're associated with each cell type. As I said before, cytogenetics, so you can see, are there any translocations like the Philadelphia chromosome, and molecular studies along the same lines. You can see if there's any specific molecules on the surface of each cell, or of each of these cell types. So, in all honesty, I don't really remember a lot of the specific details coming up. It's very detailed stuff here, but you can sort of, I guess you can stratify the risk of AML based on these chromosomal abnormalities. If you see, translocation 8 and 21, or inversion chromosome 16, you might think, okay, this patient's got a better prognosis. And and you start to worry a little bit more if you have a lot more abnormalities in the karyotypes, so in their chromosomes. If they've got multiple different sites of, I guess, defectiveness in their chromosomes, it makes sense. It's going to be a lot worse prognosis. Is there any questions on that so far? All right, okay. So in terms of the management, yeah, I mean, this is a cancer. You're going to start thinking about chemotherapy here. So say you start this patient on chemo, and then they enter remission after the first cycle, things start getting a lot better. Then you do some HLA typing, and you realize, okay, he's got a sibling donor. What kind of therapy might you start to try and offer this this gentleman? Okay, so we can sort of break this down. This patient's come in with a leukemia, an acute myeloid leukemia. You've also just blasted his bone marrow with chemotherapy. So his bone marrow is, probably hanging on a little bit now. If you imagine, okay, he's now got a sibling with that's matched his HLA antigens, what might you start thinking about doing? So you start thinking about a bone marrow transplant, because they won't, if the sort of immune typing match up, then if you give this patient a bone marrow transplant, there won't be sort of an autoimmune reaction to that, and it's the best chance that this person will have at like having a definitive like management of their leukemia. Okay, so that's the end of case 1. I think this is where Umar takes over for the last case. So I'm going to stop sharing now.
Yeah, I
Great.
will just start sharing the slides again. Okay. Let me know if you guys can see the slides. Can you guys see the slides at case 2?
Yep.
Okay, fine, thank you. Okay, so we've got previously well 37-year-old male who presents with easy bruising and intermittent epistaxis for the last 5 days. The FBC shows a HB of 12.6, a white cells of 4, and platelets of 27. What we think in terms of interpreting these blood results? Would someone just like to interpret for me? Just don't have to give me a diagnosis or anything. Just simply tell me what's wrong with these blood results, if anything.
The hemoglobin is low. I think the white blood cell count is low, and the platelet is low. Normal.
So, in terms of that, it's important to look at the kind of the exact units they're using. So in this case, HB 12.6 is actually normal because it's kind of in the grams per deciliter. I think I'm correct in saying that. So kind of it'd be 126 in the other way we think about it, but 12.6 is fine. The white cells are a little bit, they're not low, they're on the lower end of normal. But then the main thing that's low for us here, and obviously just remember, guys, in the real exam, you'd always get your kind of reference ranges, so nothing to worry about there. But I guess when you start doing questions more and more close to the exam, it'll become kind of more obvious what is wrong, and you can quickly start thinking about things. So in this case, the platelets are the most worrying thing. There's a thrombocytopenia here, and 27 is actually very low in terms of platelets because we're normally thinking either 150 to around the 400 region. So we've got low platelets, a normal hemoglobin, and white cells are on the lower end. Easy bruising, intermittent epistaxis, and importantly, previously well. So what kind of investigations do we think we might want to do? Patients come to you in A&E with this presentation. What are you going to start thinking about doing?
Have a look at their clotting profile.
Brilliant. Have a look at that clotting profile. Yeah. Any others? Any other investigations you might want to do?
INR.
Could do. Yeah, definitely. I think it's always important to kind of think basics as well. And like, this is a kind of tip for like OSCEs and stuff. If you ever get a case in OSCEs and they ask you for like which blood test you want to do, more often than not, if anything, normally always, your basic FBCs, USNEs, LFTs, they can always be helpful. And normally it's good to also say why you're doing a test. And for LFTs and USNEs, saying just I would like to order FBCs, USNEs for baseline renal function and LFTs for baseline liver function. It makes it sound like you know what you're doing. You've got actual justification for the test. You're not just saying it randomly. And they're always good baseline tests to do that most people will kind of get if you're unsure of the diagnosis or things like that, just to see if anything's affecting the kidneys, anything's affecting the liver. So I guess sometimes just get used to almost saying those kind of the basic bloods. But other investigations kind of include, yeah, as you said, coagulation screen. A blood film could be really good in terms of showing us what's going on. A tumor lysis screen, baseline virology, flow cytometry and bone marrow aspirate. I guess that's more of your higher end diagnostic tests. More often than not, just focus on the basic ones initially, especially if this was to come up in an OSCE or even, if in an SBA it asked you for an initial investigation, you wouldn't go to those kind of more higher end tests because they're never really going to be your initial. But if they ask definitive, then yeah, they're more likely. Okay. So this is what the coagulation screen shows. So we've got a PT of 18 seconds, which is slightly long, an APTT of 42 seconds, which is prolonged, fibrinogen of 0.7, which is quite low, and a D-dimer of 2000, which is quite high in this case. Now, does anyone want to talk me through these findings and maybe what it could mean in the context of the presentation? It's a bit of a tricky one, but there is a specific kind of thing actually which presents with this kind of coagulation screen. A kind of prolonged prothrombin time, prolonged APTT, as well as a low platelet count and low fibrinogen. If anyone knows what presentation that could be linked with.
Has he got DIC?
Yeah, DIC is exactly what we're looking for here, because of the low fibrinogen, the high APTT, there's that kind of table you sometimes see on PassMed of the different kind of things and what they do to your PT and your APTT. It's important to learn that table and understand kind of parts of that table. So yeah, disseminated intravascular coagulation, where there's just basically too much clotting. The coagulation process has all been dysregulated as a result of a particular trigger. Now let's think about what that trigger might be or what that cause might be. Can anyone describe to me a little bit about what's going on in this blood film? Okay, so what we're looking for here and the things we can see these big kind of purpley circular things. They are what we consider as blast cells. Now, blast cells you commonly see in leukemias, in kind of acute leukemias especially. You can see these blast cells which have a high nucleus to cytoplasm ratio. As you can see, the nucleus is taking up a large part of the cell, and that is making us think possible cancer, possible leukemia. And then if you know in your head that kind of leukemia is caused, leukemia can be a cause of DIC, you can think that. And then because if you've got a young patient, a 37-year-old, the more likely one could be APML, acute promyelocytic leukemia, and kind of it can present with DIC. But it's important to know it can be kind of chemosensitive. It's quite a niche one. We kind of didn't made these slides have been made from like a year or two ago. It's quite a niche one, but still something to bear in mind because they do kind of ask these niche questions occasionally. But yeah, I think that's it for the session. Has anyone got any questions? And again, if anyone missed the feedback form before, if you could please just fill it in. It kind of helps us in terms of seeing where we can improve in terms of these teaching sessions and help MedSoc in terms of the different things. Has anyone got any questions for me or Josh?